Chapter 33 discusses different disorders of renal function. So, when we talk about disorders of renal function, your kidneys, just like any other tissue in the body, are subject to many of the same types of disorders that can affect, any body structure or tissue. So, they can suffer from things like developmental defects. We see changes or damage to the kidneys related to different infections. Some are related to different altered immune responses. And some are the result of neoplasms or cancerous formations. So we're going to start by talking about cystic diseases of the kidneys. There are a lot of different disorders of the kidney that we won't discuss here. So really, when you're studying and looking at things, make sure to reference the material as far as what's in the presentations and also what's in the ULOs to kind of narrow down your focus. But with cystic diseases of the kidneys, our patients are developing these fluid-filled sacs or segments within the nephrons inside of the kidneys that become dilated. And so that kind of the tissues surrounding those fluid-filled sacs start to kind of stretch. Um, this can be caused by things like tubular obstructions that increase the pressure inside of those tubules, and that's what's kind of causing these fluid-filled sacs or outpouchings to occur. And they can also happen because of changes in the basement membrane of the renal tubules themselves that can lead to this kind of cystic dilation of those tubules. So there are a lot of different types of cystic kidney diseases. There are simple or acquired renal cysts. There are medullary cystic diseases, and then there are polycystic kidney diseases. And these can be either autosomal recessive or autosomal dominant in nature. And we're actually going to talk more about that final one, the autosomal dominant polycystic kidney disease types. So this is kind of what polycystic kidney disease looks like in the autosomal dominant polycystic form. So you can see within the kidney itself, many areas of kind of that dilated tubule that start to fill with fluid and become kind of these cysts, have this kind of overall cystic appearance. So cysts originate from the walls of the tubules themselves in polycystic kidney disease. This is the fourth leading cause of renal failure in the United States, behind hypertension, diabetes, and glomerulonephritis, which we'll talk about at the end of this presentation. But as these cysts develop throughout the kidneys themselves, they start to cause destruction of the normal kidney tissue. This disease is usually pretty slow in its progression and early on relatively asymptomatic. If symptoms do start to form, some of the symptoms we see are things like pain and bleeding. These are often maybe acute, and the reason that they happen is because the cysts themselves may rupture, and that's what leads to sudden kind of pain and bleeding that we would see as hematuria or blood in the urine itself. These patients are also predisposed to things like kidney infections. They also are more prone to hypertension. Their kidneys often become enlarged. So if we look at these kidneys, maybe on ultrasound, they'll look quite a bit larger. They'll have, again, this cystic appearance. And they also have more frequent what we call extrarenal manifestations like aneurysms, meaning aneurysms form in other areas of the body outside of the kidneys themselves. So things like intracerebral aneurysms are also common in these patients. They don't just get these dilations within the kidneys themselves. They can happen in blood vessels in other areas of the body. So we usually diagnose polycystic kidney disease through things like ultrasound or CT, especially in those patients who might have a genetic predisposition. Because again, this is an autosomal dominant inheritance pattern. So we're watching for this to develop very closely in patients who have first level relatives who also have polycystic kidney disease. The treatment is often supportive in nature and really focused on lifestyle modifications. So that includes things like really aggressively keeping these patients' blood pressure down, making sure they stay really well hydrated. We also may monitor and reduce their sodium intake and make sure that they don't smoke. And we're constantly screening them for complications like development of kidney diseases or aneurysms in other areas of the body. We also want them to avoid any medications that might be renal toxic. Things like NSAIDs would be important to avoid in this patient. And because they're predisposed to infections within the kidneys themselves, we want to really monitor them for the presence of UTIs and treat those early on if they were to develop. Another issue with the renal system is urinary tract obstruction. So, urinary tract obstruction can involve any level of the urinary tract, anywhere from the urethra, kind of way down on the bottom, all the way up to the renal pelvis. So, that obstruction can occur within, again, within the urethra, so below the level of the bladder. It can happen at the level of the bladder itself. It can happen in either ureter. So often when we see urinary tract obstruction, if it's at the level of the ureters, those might be unilateral in nature, but sometimes bilateral if we have constriction in both, all the way up to the renal pelvis, which is this area where the kidneys themselves meet the ureters. Okay. These can be caused by developmental defects. So some babies are born with urinary tract obstruction already developed. A very common cause of urinary tract obstruction, especially in adults, are calculi or stones. You can see that kind of depicted in the picture here, and we'll talk more about why stones develop and how we prevent them in a moment. Pregnancy can also cause urinary obstruction from the fetus just sitting right on some of these outflow structures within the renal system. BPH, or benign prostatic hyperplasia, is a cause of urethral obstruction, and that, if severe, can cause bilateral obstruction because of how low in that renal system it is. Sometimes scar tissue that results from maybe infections of the ureters themselves or from inflammation can cause this. Post-kidney stone is a common time that we see scar tissue formation, especially in the ureters themselves. As those kidneys pass through the ureters, they leave behind scar tissue that can lead to urinary tract obstruction. And other things like neurological disorders, such as spinal cord injury that impair our ability to empty the bladder, can also lead to urinary tract obstruction. We'll talk about that piece, that neurological damage, a bit more when we talk about bladder health itself. So, damaging effects of urinary obstruction. So, what happens in that renal system if we get significant urinary obstruction? Well, one big issue is that stasis of urine overall. The forward flow of urine is an important protective mechanism to prevent infection within the renal system. So anyone who has stasis of urine is predisposed to infection. And they're also more predisposed to things like stone formation. So as that urine just kind of sits, it's a larger opportunity for any kind of supersaturated components within the urine to start forming a stone or starting to crystallize. Um, and also what we see if there's urinary obstruction is the development of this back pressure. So if urine can't flow forward, it starts to back up and can back up all the way into the kidneys, and it causes significant increases in pressure within the kidneys themselves. And if we have pressure developing within the kidneys, it can start to interfere with renal blood flow to the kidneys themselves, and that can destroy the tissues within the kidneys. When we talk about backflow of fluid into the kidneys, we often term that hydronephrosis. So that is a urine-filled dilation of the renal pelvis caused by urinary obstruction. That obstruction can be either bilateral or unilateral, depending on the area that it happens. As we mentioned, if it happens in the ureters, it's often unilateral, just one side. But if it's lower, either in the bladder itself or in the urethra, it's more likely that that significant hydronephrosis would be bilateral in nature. You can see that there are several different degrees of hydronephrosis based on how severe the obstruction is. Grade 1, we have very mild obstruction, all the way up to grade 4, where we have almost complete obstruction of that ureter, and all of this kind of backup and dilation within the kidney itself. You can see here, this is the renal pelvis. You can see that significant degree in this grade 4 in the amount of renal pelvic dilation as that urine backs up. And again, all of this kind of back pressure will start to impede inward flow of blood supply that can lead to damage of the kidney tissues themselves. And so the amount of damage that we see, especially from things like hydronephrosis, are usually caused by a few different things or dependent on a few different things. One is the site of obstruction. Again, the lower in the urinary tract that obstruction occurs, the more likely we might have something like maybe a bilateral hydronephrosis. If it's just one side, we may just have it unilaterally. And it often depends on the cause. of the urinary tract obstruction. The other thing that can change the amount of symptoms that we see with urinary obstruction is how rapidly that condition develops. If obstruction develops slowly over time, we usually see less severe symptoms as the body can kind of compensate for that obstruction. But if it happens very suddenly and all at once, we might see more severe symptoms. And some of the common symptoms that we see are things like pain, so especially things like flank pain, um, pain in the lower back associated with, kidney issues. We also might see things like signs and symptoms of UTI because that stasis of urine predisposes to infection. We see different manifestations of renal dysfunction. So we might see things like changes to lab values, like increases in BUN and creatinine involved. Over time, if this isn't cleared, we might see changes to things like GFR. So any of those kind of clinical manifestations that we see in regular renal dysfunction may occur here. Often we see as far as urinary symptoms early on, especially with maybe incomplete obstruction or um, unilateral obstruction. We might see an early inability to concentrate urine. So our patient might actually develop things like polyuria or nocturia, which are common in urinary concentration disorders. Um, if we have complete urinary tract obstruction, like low obstructions within the urethra, we might see oliguria or lack of urinary output. Hypertension also can happen in some cases, especially if we have significant backflow pressures that are developing. Usually, if we relieve the urinary obstruction, that hypertension will subside. But if it has gone on long enough to start damaging kidney tissues themselves, hypertension may not even resolve once we've cleared that obstruction. It just really depends on how significant any damage is caused by that backflow pressure. Um, Diagnosis and treatment is usually done via things like ultrasound or other radiologic uh, procedures to look for kind of that dilation of the kidneys themselves from hydronephrosis. And treatment is really to relieve the obstruction. We need to figure out what the cause of that obstruction is and really go in and take care of it so that we can relieve that back pressure. As we mentioned, kidney stones are a really common cause of urinary obstruction. So the definition of a kidney stone is a crystalline structure that forms from components found naturally in the urine. So the urinary environment is said to be something called supersaturated, meaning it has high levels of things like calcium salts, uric acids, magnesium, ammonium phosphates, cysteines. All of these things are different components that can form together to create a kidney stone. Other requirements for formation of a kidney stone is something called a nidus. A nidus is thought to be the nucleus of the crystals that form a kidney stone. So all these crystals kind of aggregate or stick to that nucleus or nidus. It's usually made up of different ion clusters that come together to form that kidney stone. A urinary environment that supports continued crystallization of stone components is also required to develop kidney stones. Not everybody who develops kidney stones, and almost everybody has supersaturated urine. So there are some things that prevent certain people from developing these as well. So having said that, there are different factors that can influence the formation of kidney stones. So part of it is how concentrated those stone components are within the urine. The more concentrated those components are, the more likely someone is going to develop a stone. Also, the ability of stone components to complex and form stones. Some stone components are more likely to do that than others, and so that is also something that can play into the development of kidney stones. And finally, the presence of substances that might inhibit stone formation. As I mentioned, not everybody who has supersaturated urine goes on to develop kidney stones. So there are some things that appear to be, somewhat protective of the development of kidney stones. And one thing involved in that is the presence of things like magnesium and citrates. Those things can actually decrease crystallization, especially crystallization caused by calcium stones, which are really our most common type of stone. So again, that explains why not all people with supersaturated urine go on to develop kidney stones. Again, they may have higher levels of things like magnesiums and citrates that negate that kind of crystallization effect in the urine. So we have a lot of different types of kidney stones. We can have calcium stones that can be made up either calcium oxalate or calcium phosphate. Calcium stones are really the most common. type of stone and are often associated with conditions that increase things like bone resorption. So maybe a patient who has significant immobility, or a patient with hyperparathyroidism, or a patient with bone disease that's causing release of calcium into the serum. So those are some conditions where the development of calcium stones may be more likely. Okay. These patients are often also culture positive for things like E. coli. So it's very common for patients who develop kidney stones to also have simultaneous infections as well. This has to do with the amount of kind of like inflammation and irritation of the different tissues within the urinary tract that makes it easier for different infections to kind of take root within those tissues at the same time that stones are forming. Magnesium ammonium phosphate can also cause kidney stones. Those usually occur in patients who seem to have more very alkaline urine. And those are stones that often grow to fill kind of the entire renal pelvis. We term those staghorn stones. Those are stones that are almost virtually impossible for a patient to kind of pass on their own because, again, they fill the entire renal pelvis. They almost look like they call them staghorn uh, stones because they look like a set of horns that you would see on a stag or like on an animal. And so because they kind of hook around that renal pelvis, they won't move. And so those are things that need to be removed by some sort of usually surgical procedure that we'll talk about in a moment, because again, they won't pass on their own and they can be very painful. A very small percentage of stones are what we call cystine stones. Again, very small percentage of these. These are usually the type of stones that we would see in children who don't make up a very large population of those who get stones. But if we do see them, they're usually cystine in pediatric populations. And finally, there are uric acid stones. Uric acid stones are associated or more commonly seen in patients with increased BMI and those who have really low urine pH, so more acidic urinary environments. This is a type of stone that has seen a steady increase in its occurrence, most likely related to that steady increase in BMI among our patients. So what do we do about kidney stones? Well, first we have to diagnose that they are even present. So some of the common clinical manifestations that we see in patients with stones include things like severe flank pain. They also are often associated with different kind of like sympathetic sort of related symptoms, things like pain, nausea, and vomiting. We also see things like cool, clammy skin in these patients. In addition to flank pain, they may also have abdominal pain that radiates to other areas of the abdomen. Um, if we have a patient who's predisposed to kidney stones, we often look at preventative measures. So patients who maybe have had previous stone diagnosis, we might look at things like dietary restrictions. We might look for calcium salt supplementation. So if we have a patient who's heavily supplementing with calcium salts, we may recommend that they don't do that anymore, especially if they're taking calcium supplements. We might give these patients thiazide diuretics to kind of increase some of the renal excretion of some of these components that might lead to stone formation. We can also use something called cellulose phosphate that can reduce the amount of stone formation. If you have a patient with active kidney stones, you want to kind of aggressively treat them for pain. Um, in these cases, so things like usually opioid pain relief, often, through intravenous mechanisms because of the level of pain they experience. We also often give antibiotics, again, because of that increased risk of simultaneous infection with kidney stone formation. And then we can work to remove the stones. If a patient can't pass those stones themselves, we can do different techniques or procedures, things like ureteroscopic removal, where we go up into the urethra and into the ureters themselves to pull those stones out. We can do percutaneous removal, where we go in through the skin to remove those stones. Or we can do what we call extracorporeal lithotripsy, where we use kind of alternating sort of pulsations to sort of break up those stones within the kidneys themselves, and then hopefully the patient will pass them kind of on their own. If people do have stones that they're passing, we should try to collect those stones to analyze them. We do want to determine kind of what type of component makes up that stone, because whether it's uric acid or calcium or magnesium, the treatment that we might use to prevent stones in the future is often very dependent on the type of stone that someone is developing. So another thing that can occur within the urinary tract are urinary tract infections or UTIs. Sometimes what we see in a patient is what we call asymptomatic bacteria. Um, in these patients, they have bacteria in the urinary tract itself, but it's asymptomatic, meaning that they don't have any kind of it's just a colonization essentially. So they don't necessarily maybe need treatment for this. It might just kind of be watching and waiting as long as there's no symptoms forming. But people can also go on to develop symptomatic infections where they have actual clinical manifestations of a urinary tract infection. And these infections can be in the lower UTI or lower urinary tract, as in the case of cystitis or infection of the bladder, or in the upper UTI, as is the case in something like pyelonephritis, where we see infection within the kidneys themselves. And those often start as maybe a lower UTI, and those infectious agents start to migrate or make their way up into the kidneys themselves. And that's when we start to see the development again of something like a pyelonephritis, which is again infection of the kidneys. So what causes UTIs? Most UTIs are that are uncomplicated in nature, meaning easily treated, are caused by E. coli, and that has to do with proximity of fecal tissue to the urinary system itself. There are other pathogens that can also cause UTIs, and some of these cause more complicated UTIs. So staph is another thing that commonly causes maybe uncomplicated UTIs. But other gram-negative rods like Klebsiella and Enterobacters or Pseudomonas may also cause UTI. And some gram-positives like group B strep, those are things that are more associated with complicated UTIs. Okay. Again, most UTIs are caused by bacteria that enter the system through the urethra itself. So UTIs are often associated with stasis of urinary flow, so often with things like anatomic obstructions, like stones or prostate hyperplasia. We often see more UTIs in pregnancy as well because of the obstruction to the urinary system itself. And people who are predisposed because of malformations of the ureterovesicular junction. And so this type of UTI is the one that we usually see if we're getting UTIs in very young children, because that's a congenital malformation that leads to urinary stasis. Okay. Other causes, things like functional obstruction of the bladder itself, so patients with neurogenic bladder who can't empty, patients who are experiencing infrequent voiding for whatever reason, patients who have problems with the muscles of the bladder itself, and also patients who have significant constipation, because that constipation can start to cause pressure on the urinary system, leading to a reduction in outflow. So within the urinary tract itself, we have a lot of different protective mechanisms that prevent the development of UTI. So one is the washout phenomenon. Just that forward flow of urine helps to wash out any bacteria that are sitting in there that prevent UTI. That's why patients with urinary stasis are very predisposed to UTI. The mucin layer within the urinary tract also provides a protective mechanism. This lining provides a barrier to protect against bacterial invasion. There's also a local immune response. Within that protective barrier, we find IgA antibodies, which can mount a defense against any pathogens before they can settle into the urinary tract themselves. We also have a lot of normal flora, especially in the periurethral area in women, that protect us against urinary tract infection. So that's why we see more increases in UTI development, maybe when women are taking antibiotics or postmenopausal, because that causes changes to the normal flora of that periurethral area in women. In men, we also have prostate secretions that help to protect against bacterial invasion into the urinary tract itself as well. So once someone develops an acute episode of cystitis or acute episode of a bladder infection, the characteristics we see are usually a significant increase in the frequency of urination. These patients may go to the bathroom as often as every 20 minutes because of all this kind of irritation that's happening to the bladder because of the cystitis. They often develop things like lower abdominal or back pain. They have burning and pain on urination or dysuria, and the urine itself starts to become kind of cloudy and foul smelling as well. So, sexual activity in women is one of the biggest risk factors for the development of UTI, especially in young women and especially those who are using spermicidal agents during sexual intercourse. So, often with sexually active women, we see a significant increase in the development of UTIs. Pregnant women also develop UTIs far more frequently because of bladder displacement. Pregnancy also causes a lot of smooth muscle relaxation, which can further lead to stasis of urine within the bladder itself. And pregnant women also are often have asymptomatic bacteremia. That is a common complication that can lead to cystitis or even chronic pyelonephritis. It is important to screen pregnant women um, frequently for the development of UTI because things like pyelonephritis can lead to preterm labor. So usually when women are receiving prenatal care, it includes screening for UTIs pretty much at every visit. There are some age-related complications as well. Again, if we're seeing UTIs, especially UTIs that are developing in boys within the first 3 months, we have to be thinking about some kind of congenital malformation that's causing urinary stasis. Um, any child too with unexplained fever and UTI should be investigated for some sort of underlying obstruction kind of related cause. Again, UTIs, especially symptomatic UTIs, are very uncommon in young children, and so we really have to figure out why they're happening. In elderly patients, the signs and symptoms that we see in UTI are often very vague. So things like anorexia or fatigue, weakness, changes in mental status. Um, those are the things that we see in patients, not those kind of typical symptoms that we already talked about that are more common in young folks, things like, pain and fever and urinary changes. Those are usually not as kind of like common and obvious in older patients. So diagnosis and treatment, usually we diagnose these based on symptoms and examination of the urine itself, and we'll also look for the presence of microorganisms and other components within the urine. We can also do x-rays, ultrasounds, CT, renal scans, and usually when we're doing this, we're trying to find different contributing factors to UTI. If it's just a common UTI that we might see in maybe a sexually active woman, we often don't do these other extensive kind of uh, you know, um, um, imaging series. But if it's maybe in a young person who we wouldn't expect UTIs, then we might go a little further to look for contributing factors. Treatment of the UTI is usually based on the pathogen causing the infection. As I mentioned, there are a lot of different pathogens that cause the UTI. So we usually might do something like a culture and sensitivity, looking for the type of organism involved, and then looking for what type of antibiotics that could be used to easily treat it. This is a common urinalysis result that we might see in a patient with UTI. So a couple things I want to point out here. One is the appearance, the overall appearance of the urine itself, kind of cloudy and sort of thick and yellow in appearance. It's usually has a foul smell to it. The other thing I would point out is the presence of bacteria. This urine is bacteria positive. The other big thing we often look for in a urinalysis result is this nitrate level. Sometimes when we collect urine from a patient, especially if it's just done maybe with a clean catch where they just urinate into a cup, it is not uncommon that these samples become kind of contaminated with bacteria that are just living on the outside of the urethra themselves. So if we often look for multiple signs in the urine besides just bacteria for that reason. If it's just bacteria and we don't see any changes to the urine and we don't see any positive nitrates, then we might just call that a contaminated sample. But if we see changes to the urine itself, combined with nitrates, combined with the presence of bacteria, that is more indicative of a UTI. Then we'll talk about a condition called glomerulonephritis. This is an inflammatory process. This is the second leading cause of kidney failure worldwide, third leading cause in the US behind diabetes and hypertension. This glomerulonephritis is usually caused by some sort of immune mechanism. So maybe glomerular antibodies that are attacking the tissues themselves. And one common cause is circulating antigen antibody complexes. And so we talked about these when we talked about um, different types of hypersensitivity reactions. One thing that can cause glomerulonephritis are these hypersensitivity reactions caused by these circulating antigen antibody complexes. So some characteristics of glomerulonephritis, one is hematuria, and so red cell casts or blood within the urine itself. Um, these patients often have a diminished GFR. They also have the presence of azotemia or nitrogenous wastes in the urine. They can develop oliguria, and they often develop hypertension. So again, there are multiple causes, but they're usually immunological in nature of glomerulonephritis. So any disease that can provoke a proliferative inflammatory response of the endothelial, mesangial, or epithelial cells of the glomeruli themselves. So things like lupus or post-strep infection, we might see these immunological responses that start to damage the kidneys themselves. And this inflammatory process causes damage to the capillary walls that permits red blood cells to escape into the urine. And it can also produce hemodynamic changes that can lead to decreases in that glomerular filtration rate. So there are a lot of kind of cellular changes that we see at the glomerular level in these patients. We can see things like thickening of the basement membranes themselves. We can see sclerosis or fibrosis of those tissues over time. And this leads to things like leaking of protein or blood into the urine. It can lead to, again, hypertension and the development of increased nitrogenous waste in the serum itself. Finally, I'll just mention some of the renal neoplasms. In children, we might see something like a Wilms tumor. These are embryonic kidney tumors, again, that occur during childhood. The onset of a Wilms tumor is usually at about 3 to 5 years, and it can occur in one or both kidneys. It's usually a chromosomal mutation that causes this. The parents of these children will often find these during bathing, where they actually feel that tumor within the kidneys themselves. Treatment, surgery, chemotherapy, and radiation. And in adults, we also see renal cell carcinoma development. These cancers are usually silent in nature, so they grow until they're very advanced. Um, they usually present at that point by things like hematuria or flank pain, and maybe even a palpable mass. Renal cell carcinoma can be very difficult to treat, again, because of the advanced nature of that disease at time of diagnosis.